muscles. Now we learned the bones, we learned the bone markings. So now we're ready to see the muscles that attach to those bone markings. So I'm going to do the actions later. And these you probably learned when you did the joints. So it's a good time to revisit that once you get used to hearing these muscles, right? So this is an anterior view. He's not quite in complete anatomical position, like his thumbs are in the right place. Remember, the pollex is the thumb. The radius is lateral in the anatomical position. But the only thing I see different here is his left foot is slightly externally rotated, which really happens at the hip. So remember, this is his left. He owns the anatomy or she owns the anatomy. So you're going to be asked for left and right every once in a while on an exam. So that's something that you just have to get used to doing. Like even though it's our right we're looking at, but it's his left because he's in the anterior, more or less anatomical position. Right? So you're going to go through muscles. And some of them are paired, some of them are not. Looking at my list, it seems like most of your muscles are going to be paired, have a companion muscle on the other side, right and left, like temporalis. You're going to see the temporalis is right on top of the squamous portion of the temporal bone on both sides, right? Masseter, think mandible, because masseter is a thick muscle of your jaw. And both of these basically do the same thing. They elevate the jaw, which you'll see. And this is muscle, and these are the muscles I'm going to ask you, all of these that I circle. The orbicularis oculi. Get the spelling straight here, Yuri. You see that spelling? Orbicularis. So it's round. And oculi means eye. Because there's an orbicularis oris around the mouth, has the first name, but then the surname changes to oris, which is referring to the mouth, the oral area. Then you have this muscle. It's kind of a strange looking muscle. It's on both sides. Everything's paired so far. There's this muscle that kind of drapes from the mandible down to the clavicle, and that's called the platysma. I like saying platysma. And, spelling as close as you can, because I screw up the spelling too when I'm writing it fast. So you'll see the platysma is not on this particular picture, but you'll see it later on. Then this one, here's a big one. Check this word out. It's got like 3 parts named right in it. It's called sternocleidomastoid. All right. So sometimes we break that down to or shorten it to SCM. So look what the words are on here. Remember we talked about, or maybe we didn't, but in your lecture you talk about muscles, and there's 3 or 4 things you need to know about muscles. One is, and this is the way I would learn it, and I think this is the easiest, and use your coloring books, whatever. But the first thing you learn about a muscle is its action, because you already learned bones, you already learned joints and movements. So the action is the movement, like the masseter elevates the jaw, which is closing the jaw when you're eating your bagel, right? Then you learn the origin of the muscle. And the origin of a muscle is the fixed part. Like if the masseter is closing the jaw, the part that's not moving is going to be the zygomatic bone, right? The zygomatic bone is your cheekbone. The part that's moving is the mandible. So the mandible would be the insertion. So the fixed part that's not moving is the origin, and the insertion is the movable part, the bone marking, the bone itself. So the origin of the masseter would be the zygomatic bone, and the insertion would be the mandible, because it's closing the jaw. Because you learn the action, that's simple, you know that. Then origin insertion is difficult. And you can learn the innervation. You don't need to know that now because we're not doing neuro, but innervation, like look at the word nerve is in there. Innervation is the nerve that supplies that masseter to contract. Because you learned in muscle that muscle can't do anything without an action potential from a somatic motor neuron. In this case, it's a cranial nerve, though. It's a cranial. The masseter uses the trigeminal nerve, which you'll learn later on, which is the cranial nerve 5. But you don't have to know that for this exam. And you just generally have to know origins, insertions, and actions, right? And you're going to do some labs, virtual labs, and you should know that from your lecture. So just to keep all these things in mind, because you learn joints, so you should know the actions, the movements, and then the origins, insertions are within the joints, but on the bones, the bone markings, all those bone markings you learned, right? Like the deltoid tuberosity, the tibial tuberosity, the lateral epicondyle of the humerus. It's a lot of stuff in the bones, yeah. So let's get back to the SCM. This is why I bring this up. Look at the word sternocleidomastoid. So this SCM, sternocleidomastoid, is going to have attachments to the sternum. Cleido means clavicle, and mastoid is the mastoid process of the temporal bone. So it tells you pretty much the origins and insertions right in there. So you can remember that, and I'm going to ask you that. Of course, that's why I circled it. Then you have a big muscle that covers the shoulder called the deltoid. The deltoid is this big cantaloupe-looking thing, very superficial. So now you have to use the term superficial and deep. Now, if you look at this handsome guy, this model right in front of you, you see that the right side of this cartoon is superficial muscles, and the left side is deep muscles. Can you see that? Especially up in the pectoral girdle around the chest, right? So this right side of this picture is all superficial. The left is deep. And I'll show you that as we go. Because that gets a little difficult. Because when you do the dissections in anatomy and physiology reveal, APR, they'll show you a picture and pretty much not tell you that it's the pectoralis major has been removed, or the gastrocnemius has been removed, or the platysma has been removed, or the trapezius has been removed. So you kind of have to know that. So the deltoid, again, we're doing paired muscles. And deltoid has a front, which is anterior, lateral, and posterior part to it. Then you have the arm muscles. The biceps brachii is anterior, and you can see it from the anterior. So right here is the biceps brachii. It's called biceps because it has two heads to it, which means it has two separate tendons. So it has a medial head and a lateral head. So you know that this is lateral over here. This is lateral over here, left lateral and right lateral. Another muscle is the triceps brachii, which you really see more from the posterior view. So this one I'll start because it's on the posterior view more. And lateral, you can see it from the lateral view. So of course, the first thing you do, like I did, like with your coloring books, what view am I looking at? This is anterior view of the muscular system. The right side is superficial, sorry. The left side is deep. He's basically in anatomical position, but his left foot is slightly externally rotated. So he's externally rotating his left hip. So I can see the medial muscles. That's why he's doing that. All on purpose. Then you have a forearm muscle, which is right here. It's the biggest one. And this another muscle. Look at the names. Like triceps brachii is 3 heads. Sorry, I forgot to mention that. 3 heads, and that's posterior. Brachii means the upper arm. The brachium is the upper arm, above the elbow, below the shoulder. So I have that on the recording, so remember that. That's why it's important to listen to these recordings. Now, brachioradialis, so it says radialis, coming from the brachium, but it's still the forearm muscle. Radialis means it's on the radial side. It's going to insert in the radius. So remember, the ulna and the radius. The ulna is medial in the anatomical position, and always actually, and the radius is lateral in the anatomical position. But if you pronate your palm, like his hands are supinated right now, but if he pronates, turns his palms downward, then the radius bone is going to rotate and radiate around the ulna. That's why we have this muscle that really does that, and that's the action. So the brachioradialis is the only forearm muscle I'm asking you for. Because if I had to ask you for the other muscles, you really have a headache. Because the forearm muscles are very difficult. So if you go into medical school or PA school or OT or PT, chiro, any of those, you're going to learn those in great detail. But for us, we have enough to worry about with the bones. So just know the brachioradialis is the muscle you need to know in the forearm. Like Popeye. You ever hear Popeye, the cartoon guy, the sailor, right? The guy has huge brachioradialises, but his biceps are tiny. Go figure. I never understood that. So he beat the hell out of that big guy with his brachioradialis strength. Then you have the chest muscles, and there's two chest muscles, pectoralis major, right? Major, and that's the superficial muscle. But there's sorry, I said this is pectoralis minor. This is pectoralis major. Sorry, pectoralis major is the superficial muscle. Pectoralis minor is deep to the pectoralis major. So in order for me to see the pectoralis minor, I have to remove and dissect out the pectoralis major. So you're going to see that in APR, where you have to know the pectoralis major has been dissected off, deflected off. So now I can see the pectoralis minor. And the pec minor has completely different actions than the pec major. So remember that. And then we have serratus anterior. Serratus anterior. And that one you could see here too. Like it's got these little knife-like elevations off the rib. So I'll show you a better view of the serratus anterior. Serrated means like a knife has serrations with little grooves in them. So the serratus anterior kind of looks like that. And there is a serratus posterior, which you don't have to know. So you'll see that from the lateral view and the anterior view. Then you have the intercostals. I'll show you the intercostals later. You have internal and external intercostals muscles on both sides. Intercostal means in between the ribs. Costal means rib. So you're going to find out, I'll tell you now, so it's recorded, the external intercostals are more for elevating the ribs and taking a deep breath in, deep inhalation, where your internal intercostals are more about exhalation, bringing your ribs downward and blowing the air out of your lungs. So it's very important. They're accessory muscles of respiration. And you're not doing respiratory, so A&P2, but you'll remember this. Okay, where are we? At the rectus abdominis. So here you have these. Remember, this is on both sides. His left side is a little bit deeper because there's a rectus sheath over the rectus abdominis on both sides. But remember, this picture is, for your learning purposes, is superficial on his right and deep on his left. So there are different boxes of muscles. And rectus, now some muscles are named after their shape, like rectus is rectangular, where like deltoid is a deltoid shape. So sometimes you hear like rhomboid is a rhomboid shape. Trapezius is trapezoid shape. Like trapezius up here, but you can't really see that from the anterior so well. Like this is the trapezius on top of in the back. So be able to dissect those out. So the rectus abdominis is separated by these little areas of connective tissue. So you see a lot of white, right? You don't see it so much on the front, but usually in the white you see is not a tendon or a muscle. It's usually fascia. Remember, a tendon connects muscle to bone. A ligament connects bone to bone. Fascia connects muscle to muscle. And sometimes they call the fascia, that white part, they call it aponeurosis. So we'll see that term come up later. It's not so clear here. So there's connective tissue in between the rectus abdominis muscle. Then you have the obliques. You have external oblique, internal oblique, and then you have a muscle that kind of is even deeper called the transversus abdominis. And I'll show you a really good picture in this PowerPoint that separates these three muscles: internal oblique, external oblique, and transverse abdominis. Now for the recording, I'm going to tell you that the external oblique is the most superficial. The next muscle deep is the internal oblique, and the deepest of those three muscles is the transversus abdominis. And you'll see that compartment dissected out for you later. Very good. Very, very good. So then you have a muscle you really can't see too good that comes up from the back called the latissimus dorsi, which I'll show you in the posterior view. And we'll look at the gluteus maximus on the posterior view. Now let's look at the leg. Now there's two parts of the leg. You have your thigh and your lower leg. Sometimes I confuse those, but the thigh is the above the knee, below the hip, and the lower leg is below the knee, above the ankle. So one muscle that we always ask, it's kind of a weird muscle. I'm not sure exactly why we have this muscle, but it's called the sartorius. And it's a very thin muscle that crosses over the front of the thigh. So its origin is up here in the ilium, and its insertion is down here in the tibia. And that's called the sartorius. Now, the sartorius muscle is a very thin, long, I think it's the longest muscle in your body. And it looks like a tape measure. You know, like when you go get measured for a dress or a suit, they use a tape measure to measure. So they call it the tailor's muscle, and sartorial has to do with tailoring. So they guess they called it the sartorius muscle for that reason. So its actions kind of just help the quadriceps and leg extension, and it does some hip flexion. But it just goes along for the ride. It really doesn't, it's not a primary mover of anything. So if I cut it out, you'd probably miss it, but it really doesn't have that much function at this point in evolution. So then you have the quadriceps, which are behind or underneath or deep to the sartorius. And there's 4 quadriceps, but you're really only going to see 3. And here's the 3 quadricep muscles. So the one in the middle is called the rectus femoris. Makes sense. It's kind of parallel. You know, it's not square. It's rectangular, and it's right in front of the femur. So they call it rectus femoris. So this is in front of the femur, anterior thigh. So that's a big muscle right here that has a tendon going to the patella. So the top of the patella is suspended in the quadriceps tendon, mostly the rectus femoris. Then you have the vastus sisters. You have the vastus lateralis, which is right here. And the vastus medialis is this little teardrop muscle right here on both sides. Everything's paired so far. I'm not sure if we saw a muscle that was not paired. Trapezius maybe is technically not paired, but you'll see why. So the vastus lateralis is lateral, rectus femoris is in the middle. Now there's another vastus sister called the vastus intermedius. You might see that on APR. So that's deep to the rectus femoris. You'd have to cut the rectus femoris out, dissect it out, and see it deeply. So I don't think it even shows you on this picture. But this is a general picture. We're going to go a little deeper as we go into this PowerPoint. So those are your quadriceps, and know them well because I'll ask you every one of them, except for intermedius. I won't ask you that one. And then we'll look at the back of the leg to see the hamstring muscles, the posterior thigh muscles later. But this is a tough compartment in here. There's a group right here, and these are the adductor muscles. The adduct, that's the action. They bring the leg closer to the midline, the femur really. The tibia and fibula just go along for that ride. So you have a large muscle called the adductor magnus, but that's seen more from the posterior view. Adductor means bringing closer. Abduction is the opposite. The adductor magnus is the big adductor. Magnus means big. So adduction is in the name, right? It tells you the action. It's another reason why it's good to learn the actions first. So you're not going to see that on the anterior. So this is a key muscle right here, gracilis. It's the thinnest and most medial of the adductors. This is not a great picture to see it. I mean, it's right here, but you'll see it later. And then the next one medial is the adductor longus. I'm going to go through this again, so don't worry. And then there's a muscle that's even more medial, and you see its insertion is up here. I'm sorry, its origin is up here on the pubic bone. Its insertion is down on the femur. And that's called the pectineus. Okay, so we'll go through those. Now this makes sense. Let's go to the lower leg. And this bone right here, the most medial bone is the tibia. Remember, the tibia is medial to the fibula. And there's a muscle that's just lateral to the tibia on both sides. It's called the tibialis anterior. Makes sense, right? We see it on the anterior, and it's on the tibia, so it's the tibialis anterior. Makes complete sense. Then in the back of the leg, you can see it here. Like if you see, these are your calf muscles, the two big heads of this monster called the gastrocnemius. I don't remember why they call it gastrocnemius, but that's one. Look at the spelling there. Look at that, Arden. You're gonna have to spell that on the exam, because of course I'm going to ask you the gastrocnemius. And there's a medial head and a lateral head. So posterior, let's review. I could probably find some. Here's the SEM. Remember that one? Sternocleidomastoid. And you're going to get a better view. And we're going to go over to APR later, and we're going to look at it together. Then you have this big trapezoid-shaped muscle called the trapezius. That's like that little elevation posteriorly on your back that you could see that from surface anatomy. It's shaped like a trapezoid, like a diamond. So it has insertions up on the occipital bone and has origins down here on the thoracic or the thoracolumbar fascia. So let's talk about that. Like this white stuff here is aponeurosis, right? The white stuff is aponeurosis. That's a tough word. Has nothing to do with your brain. Nothing. But it's also fascia. Same thing, connecting muscle to muscle. So that particular one, this is the thoracolumbar fascia or aponeurosis. This big white thing here is called the ITB or ITT, called the iliotibial band or iliotibial tract, and that's completely lateral. Right, this is the iliotibial band on the right. Then you see this white thing down here. I will ask you this, so pay attention to this recording. This is the calcaneal tendon. So it's really the tendon of the gastrocnemius, which is here. And it attaches the gastrocnemius to the calcaneus. That's the insertion. And you'll see that later when I do the actions. So the calcaneal tendon is also known as Achilles, because if you read the Iliad, you know that Paris shot the arrow through Achilles' calcaneal tendon to stop him from continuing on in battle. The legend has it. So you could see the Brad Pitt, right? You could see the sternocleidomastoid. You could see the trapezius. Here's the deltoid. Right here and here. Remember, this is, now we're looking for as posterior. So this is left. All right, correct. And this is right. Posterior view now. This is the posterior view. Now you got a good look at the triceps brachii, right? Triceps brachii. You could see, get a piece of the brachioradialis papi, which is lateral, thumb side, which helps radiate the radius bone over the ulna during pronation. And supination brings it back. Crazy, right? So let's meet another muscle. Here's a big, look at this spelling. Check this out, Yuri. The latissimus dorsi. Sometimes they say lats. And it's like a big cape-like muscle. It has its origins down here in the thoracolumbar fascia, but its insertions are up in the humerus. So it has something to do with extending the arm backwards. Important. Okay. Then you have this big muscle right here in the, I could say gluteal region, because that's why they call it the gluteal region. That's where you have the gluteus maximus. Gluteus maximus. The gluteus medius is below. It's slightly different actions. Not below. It's superior above in this picture, but in a real dissection, it's not always like this. Sometimes it's deep to the gluteus maximus. So gluteus maximus is the one you need to know. We're getting there, all right? Then now you could see the adductor magnus, and I'll have to show you in APR where to find that. And that gets a little confusing right here. This is where, and the reason it gets confusing is because you're looking at cartoons, you're looking at models, you're looking at real anatomy, cadavers, and real anatomy are like people. Cadavers were people at one time, and everybody's slightly different. So sometimes the anatomy is going to show itself a little different, which really gets you confused. And unless you're using a coloring book, then it's straightforward. You just put it where it's supposed to be. But we're using APR, so we have to go into that and look at what I'm going to ask you for these muscles that I'm talking about now, especially the adductor, magnus, adductor longus, pectineus, gracilis. But these are especially varied. But I'm going to give you some general rules with these. Now, these three are your hamstring muscles, and you have to know them all. So biceps femoris, remember, it's not, you have to know the difference between this and the rectus femoris. The biceps femoris is the most lateral and the largest of the hamstring. Most lateral, right? Now, this is telling you, this picture here is showing you the semitendinosus is in the middle, and the semimembranosus is slightly medial. But I have to show you an APR how we're going to do that because it varies. But know this. Now, this is the general rule. The most medial muscle between your legs and your upper thigh and your thigh is the gracilis, which is an adductor muscle. The next one over is usually the semitendinosus. The one in the middle is the semimembranosus, and the most lateral hamstring is the biceps femoris. So gracilis is an adductor, an adductor, but the three hamstrings are in a row, and I'll show you because they kind of overlap. But here's what you should know. Know that the biceps femoris is the most lateral, and it's the biggest. And then we'll figure out semimembranosus and semitendinosus on the APR, because that's where we're going to test you from it. So that's the only fair way to do it, I see. Then you have the gastrocnemius. Get the spelling. April, you with me? Spelling that? That's not easy. And you have, the medial head and the lateral head. Medial head of gastrocnemius, lateral head of gastrocnemius. The soleus is deep to the gastrocnemius, but they share the same calcaneal tendon, Achilles tendon. And I'll tell you right now, the gastrocnemius is important for plantar flexion, which bringing your toes downward, like pressing on a gas pedal. The tibialis anterior, which is on the anterior side, obviously, is more about bringing your foot upward, your toes up towards your shin, towards your tibia. And that's called dorsiflexion. So the top of the foot, if you look down at your foot, the top of your foot is called the dorsum. The bottom of your foot, the sole of your foot, is called the plantar surface. So that may help you with the actions. And the gastrocnemius and soleus, their action is plantar flexion, pointing the toes down. The action of the tibialis anterior is dorsiflexion, bringing the toes upward. So dorsiflexing the ankle, really. And gastrocnemius, plantar flexing the ankle, toes coming down. So the calcaneus is the insertion for the gastrocnemius, and the dorsum of the foot is the insertion for the tibialis anterior. So that's a good overview. Now we could break it down a little bit. And now this is pretty superficial. So let's look at the muscles we need to know. Like this gala aponeurotica, or occipitocranial aponeurosis, is all connective tissue, right? It's like a little cowl across your head that connects the occipital belly and the frontal belly of the occipital frontal aponeurosis. But I'm not asking you that. But you should know that the white is fascia. That's aponeurosis. Here's a great view of the temporalis, don't you think? No question, that's the temporalis. All right, and remember this one, orbicularis oculi. Right, because you have other muscles, facial muscles like zygomaticus, buccinator, risorius. Right, and you should know the orbicularis oris. So when I make a joke and you're just trying to be like respectful and you just kind of fake a laugh, then you use like the zygomaticus and the risorius to smile. But when you use your orbicularis oculi muscles to laugh, that's a real laugh. And your brain knows the difference. Just a little fun fact there. Okay, what else do we have to know? The masseter. The masseter. Look at, now you can see it, right? Now you can see that thick muscle there. You can see the platysma. Get the spelling. The platysma really isn't a major moving muscle. The only thing the platysma does is kind of like draw your mouth down into a grimace. So it's a muscle of facial expression. Like when you see your grade on the practical, you make that grimacing face. So that's, you're contracting the platysma. It's a grimace, if you know what I'm talking about. The SCM, sternocleidomastoid, our old friend from a couple of minutes ago, is right here. And you could palpate that. You could feel it. Like when you take a carotid pulse, you feel the pulse of the carotid artery. You pretty much feel right in front of the sternocleidomastoid. And you catch a piece of the trapezius on the lateral view. Remember, this is his left lateral view. I didn't even say that. Left lateral view of this cartoon drawing. And it's superficial. It's not a mid-sagittal. Mid-sagittal will be right through the middle of his head when we look at the skull. We don't look at that too much in this class. So I think that's everything circled that you need to know on this view. This one is, we're not going to go too deep on this one, but I need you to know a couple of things. First, remember the mandible, the angle of the mandible here, the mental foramen, right? Mental foramen, the mandibular condyle, the coronoid process of mandible. So it shows you some of that. The alveolar margin of the mandible, which means teeth, alveolar. And remember this thing, the hyoid bone. So make sure you know hyoid bone. It might show up on this practical. And you really don't have to know the muscles that attach to the larynx. Like this is your Adam's apple right here if you're a male. Your thyroid gland is here. These blue rings is your trachea, right, with the hyaline cartilage. This is your larynx here. So these muscles kind of help you swallow, like this stylohyoid, thyroid hyoid, sternohyoid. And they basically, if you listen to the names, they're basically telling you the origins and insertions. So their actions are about swallowing. Deglutition is a word for swallowing. But we're really interested in this muscle. And look at the origins and insertions. Look, clavicles, sternum, right? Sternocleidomastoid process of temporal bone. And this is all SCM, but it's deep, right? There's no platysma. I had to rip the platysma out. The pectoralis major is gone. All the intercostals are not there. So you have to know your point of view. So the takeaway here is the connections, origins, insertions of the SCM, right? The SCM, sternocleidomastoid. This is really good. Again, this is deep, of course. We took away the latissimus dorsi. We took away the serratus anterior. So now we're left with just the muscles that move the ribs, and they're in between the ribs, hence the term intercostals. So if you look at the direction of the muscle, and these are more external too, they are more superficial than internal intercostals. So your external intercostals have their origins on the bottom of the ribs and the insertions on the top of the subsequent bottom rib. So it brings the ribs up, it elevates. So this elevates ribs. And this is for like a deep inhalation, which I think you know what that means. Now the internal intercostals kind of go the different direction. They're grain, like, you know, like cut into a piece of meat. You notice the grain of the muscles, like the way the fibers are running, the direction really. So internal intercostals, they depress the ribs, bring them down. And this is for a forced exhalation. So internal intercostals and external intercostals. This is a view I would never give you. This is an inferior view, but really what we're looking for here is the diaphragm. So you really have to know where the diaphragm is. Please add that to your list. It's an important muscle that you'll always use as a point of reference. And it's skeletal muscle mostly, right? I mean, it's skeletal muscle, which implies that it has voluntary contraction, right? You could use your cerebral cortex, your brain, to contract the diaphragm. But it also has some autonomic innervation, meaning without the use of your brain, just it is your brain, but it's not your conscious brain, not your voluntary part of your brain. So the diaphragm is important for breathing. Because remember the external intercostals, when they contract, they elevate the ribs. But when you inhale, listen to this, you should always remember this. When you take a deep breath in, or just a resting breath without thinking about it, your diaphragm is going to contract and lower to increase the volume in your lungs, to get more air in against pressures. When you exhale, even a quiet exhalation, not even forced, the diaphragm will relax and then elevate, go upwards to decrease the volume in your lungs. So that happens autonomically or automatically or subconsciously. We don't have to think about breathing and contracting the diaphragm. The nervous system does that. But we can control it, right? You know, when Arden sings, she can control a diaphragm. Imagine the diaphragm on an opera singer or Freddie Mercury or something like that. So they can control their breathing and vocalization by using the diaphragm. So this is a good view now. Here, first of all, you see this. Let me draw it on this side. The pec major is here, right? You have that rectus sheath. This is called superficial above the rectus abdominis. Then you have this muscle here called the serratus anterior. So all this is serratus anterior. I will ask you that. So this is latissimus dorsi right here. This is pec major, pectoralis major. This is your rectus sheath. This is your external oblique. So look at the grain, the way it's, the direction of it. So this is the aponeurosis of the external oblique. You don't have to know that, but you should know that it's not a muscle. It's the connection of the muscle to muscle. And then you have a tendon that connects muscle to bone. The inguinal ligament is right here. That's a very thick, dense, regular connective tissue between the pubic bone and the ilium bone, the anterior superior iliac spine. And you can see the external oblique is superficial, the most superficial oblique muscle for lateral flexion of the trunk. And then you could see the rectus abdominis. If I point anywhere here, it's rectus abdominis. All this is rectus abdominis. Of course, now we're going to cut deeper on this side to confuse you even more. But you can see the external oblique is superficial. And look at the grain and direction of the internal oblique. It changes a little bit, right? It changes a little bit. So if you see this picture with this rectangular cut dissection, remember, external oblique, most external, most superficial, different direction of fibers, internal oblique next deep with an opposite direction of fibers. So bringing your body lateral flexion and bringing it back to midline, right? And then the transversus abdominis is the deepest of these oblique muscles. And you can see that the direction looks kind of horizontal of these fibers. So take a note of this. Okay, you know the rectus abdominis. The white line of fascia that goes down the middle and separates left and right rectus abdominis is called white line, linea alba. Why not know it, right? And pec major, over there, pec major, you need to know. So this is a good picture. Here's a view of all of them at different dissections. So the most superficial, next superficial, and deepest. So external oblique to internal oblique to transverse abdominis, or transversus. You're gonna get full credit if you put transverse abdominis. But look at the direction of the fibers. So this is basically the pectoral girdle, which is showing the pec major, right? And then you have the pec minor, which is deep. Completely different actions. So let's talk about the pec major versus pec minor. First of all, you have to identify it. You identify the pectoralis major, and it's bigger by a lot, and it's superficial to the pec minor. Now, the action of the pectoralis major is adduction of the humerus, bringing the humerus closer to the midline, right? And it does some arm flexion, which bringing your arm up from the anatomical position. The pec minor has insertions on the ribs So the pec minor is more about moving, elevating the ribs, maybe getting involved in respiration a little bit. Its origin is up here on the coracoid process of the scapula. So it's completely different. Now look at the pec major. It has a lot of 3 different main origins. So the pec major has an origin on the clavicle. It has an origin on the sternum and has some origin on the ribs. And its insertion is out on the humerus. Remember these parts, right? The sternal end of the clavicle, the manubrium, the body of the sternum, and the xiphoid process. Jugular notch, right? Clavicular notch. Sternal angle is that line. And up here you have the sternocleidomastoid, the SCM. You see it, right? Superficial anatomy. You can see a skin now, so this is actually surface anatomy. So now you can start putting it all together. Okay, now I know the acromion process is up here. That's the acromial region, right? This is the chin, the mental area. This is the angle of the mandible, all these kind of things. Look at this. You could kind of see the SCM, that little elevation that you could see in the skin. So notice the surface anatomy as well, and the bone markings and the bony landmarks. Because you're learning anatomy, this is the way to do it. Here's the biceps brachii, anterior. Brachial means the arm between the shoulder and the elbow. It has a medial head and a lateral head of the brachii, biceps brachii. And you have to say biceps brachii, because if you say biceps brachii, what are you talking about? You're talking about the biceps femoris? That's a hamstring muscle. Biceps femoris is a hamstring muscle. Biceps brachii is an arm muscle that's used for flexion of the elbow, right? Like you hear things like coracobrachialis, which tells you the origin insertion, the coracoid process of the scapula, which is anterior scapula, and into the brachialis region. And the brachium is mostly the humerus, right? The humerus. Remember the humerus? The lateral epicondyle, the trochlea, the capitulum, and the trochlea right there of the humerus. The coronoid fossa, the deltoid tuberosity. So get a look at these things. And here's your serratus anterior, which you could see from the superficial view as well. So the serratus anterior has more about inserting back to the scapula, actually. It's pretty difficult. Serratus anterior is the boxing muscle, which helps the boxer protract his arm forward to punch. Serratus anterior. So that's when I'll ask that. Serratus, like the knife, that's the boxer's muscle. Clavicle has a lot of different names, like so call it clavian, right? Cleido. So anything CLA, you're going to think clavicle, which kind of makes sense. So now we have his left side and his right side, posterior view. The right side is deeper than the left. So look at the trapezius. That's a superficial muscle. All of this is trapezius. All of this. Look at all the connections for the vertebrae, the aponeurosis, the scapula, spine of scapula, right? Here's the spine of scapula, which is always posterior. Here's the acromion process. This is the acromial end of the scapula, the greater tubercle of the humerus, right? Here's your deltoid muscle. And look at this connection right here. The deltoid muscle laterally, its tendon is going to attach to a bony marking on the humerus called the deltoid tuberosity. Crazy stuff, right? Deltoid tuberosity. And here's the latissimus dorsi. So you have to know the difference, like know where these two stop. Like if I put an X there, that's the, or if they highlight this, it's this trapezius. Here is all latissimus dorsi. Here's the infraspinous fossa of the left scapula. It's the bony part. Here's the spine of scapula. Like this word here, levator scapula, is a muscle that elevates the scapula. You don't have to know it, but there it is. Now we're getting into deep muscles on this right side deep. And look at this, just while we're here, when we see this is a floating rib, false rib, false rib, false rib, false rib. To know the ribs, true and false. So we have a muscle, and now these are the rotator cuff muscles, the supraspinatus, the the infraspinatus, the teres minor, and there's another one that's anterior called the subscapularis. So these are important to just because they tell you where they are. Like subscapularis is anterior. So where is its origin? Its origin is in the subscapular fossa of the scapula, which is anterior scapula. Now remember, when you're looking at the scapula, the spine is posterior. So there's a fossa above called the supraspinous fossa, and that's where the supraspinatus muscle is, and that's a rotator cuff muscle. Then you have below the spine of scapula, you have the infraspinous fossa, but you have the infraspinatus muscle, which is one of the rotator cuff muscles. And then you have a muscle here called the teres minor, which has an origin on the scapula and going out to the humerus. They all the rotator cuff muscles have their insertions on the humerus. And the subscapularis is anterior in the subscapular fossa. So I remember rotator cuff muscles in this acronym SITS. So it's subscapularis, infraspinatus, teres minor, and supraspinatus. Or you could say supraspinatus, infraspinatus, teres minor, subscapularis. So, but it's helping us learn the fossas of the scapula. And look at these muscles, which aren't on your list, I know, but they're named after their shape, rhomboid minor and rhomboid major. Just a tip for learning major and minor, the majors are always more inferior or below, and they're bigger, and the minors are thinner and on top, usually. Like here's the teres minor is very small in here. Doesn't show it on this side, sorry. Look at this, the olecranon process of the ulna. Olecranon, posterior olecranon, the medial epicondyle of the humerus, the head of the radius. All review. The iliac crest, transverse processes of the lumbar vertebrae. These are spinous processes of the vertebrae, and they're all spinous processes. Every vertebra has a spinous process except for C1, which is also called the atlas. C1 does not have a spinous process. It has a tubercle, posterior tubercle. So C1 is atlas, no spinous process, but the rest of them have it. Okay, just to give you some point of view. This is the medial border of the scapula. This is the inferior angle of the scapula, infraspinatus fossa. Remember, the spine of scapula is always posterior. So these bony markings are all about muscle connections. Here's the SCM, right? Here's the trapezius, portion of the trapezius. Here's your deltoid, pectoralis major, biceps brachii, brachioradialis. So see what you need to know. And triceps brachii it basically does all the same function, lateral, long, and medial heads. So that's why it has 3 heads, which you can see more from the posterior, not this view. So the action of the triceps brachii is extension of the elbow, extension of the radius and ulna, where biceps brachii is flexion of the elbow, flexion of the radius, ulna. And here's your brachioradialis, the big Popeye muscle. That's forearm muscle, right? It's antebrachial. It's down below the elbow. Don't forget the costocartilage, right? Costocartilage. Piece of xiphoid process, body of sternum, manubrium of sternum, sternal end of clavicle, acromial end of clavicle. So get your point of view. Here's your serratus anterior, right here, just along the ribs. These are all false ribs because they don't have a direct connection. Remember, the first 7 ribs, and you count downward from top to bottom, 1 through 7 ribs, both sides, are true ribs. 8 to 12 are false ribs. And 11 and 12 ribs are floating ribs, but they're also known as false ribs. So you get 100% credit for naming false or floating for 11 and 12. not for rib 10. That's a false rib. You can't say floating. So go over all that. Good posterior view, right? Here's the thoracolumbar fascia. You can see the iliac crest, latissimus dorsi. Here's some rotator cuffs like the infraspinatus, teres minor here, and teres major, supraspinatus, rotator cuff. Here's the spine of scapula, the acromion process of scapula, the greater tubercle of humerus. Look at that. It's a good picture because that's lateral. The lesser tubercle of humerus is more anterior, medial. Look, it'll say like the deltoid has been cut off. Right? You see the skin, but they cut the deltoid out. So be careful of your point of view. Here's your triceps brachii. Right, the long head is sometimes called the medial head. The short head is actually medial too, and the long head is lateral. There's your lat, dorsi, latissimus dorsi. There's your olecranon process of the ulna. And this is the radial head. Remember, this is anatomical position, so his radius is lateral, thumb side in the anatomical position. And this is the tendon for the triceps brachii, which is attaching the triceps to the ulna for elbow extension. The olecranon process is posterior. The coronoid process is anterior on the ulna. Very important. So we're not going to go deep into these muscles, but you could look at the brachioradialis here and you can see where it originates from up here in the humerus and then down here in the wrist. Thumb side, right? Brachioradialis is on the thumb side in anatomical position. This is a good picture because it shows you a lot of, this compartment, which is kind of difficult. So this is the right leg anterior view. Right thigh mostly, upper thigh. So just get an idea. Like, look, here's the 12th thoracic vertebrae, the body of the vertebrae. The blue thing is the intervertebral disc. This is a floating rib. So this is the last rib you'll see because all 12 thoracic vertebrae have ribs attached to them on both sides. The lumbars do not. So L1 will start here, L1, and then L2, L3, L4, and L5. And the intervertebral disc, the last one, and this is all sacrum, and he says the coccyx. Here's the transverse process, left transverse processes of the lumbars. You have them all the way up to C1. So now let's take a look at the deeper muscles. Now you don't have to know these. These are core muscles, deep hip flexing muscles, but you really don't have to know them. I like to point this one out though, the tensor fasciae lata, because it's right above the ITB, like this is your iliotibial band in the right lateral thigh. The TFL, we call this the TFL. It's a muscle actually, and it's an abductor, abduction. So abduction. So that's the opposite of adduction, adduction. It's actually bringing the thigh away from the midline. So pectineus is an adductor. So you have to know pectineus going across. Then we have the adductor longus, which you really see more from the anterior. Adductor magnus, you really can't see from the anterior. You have to see this from the posterior. And this one I will definitely ask you, the thinnest adductor, the most medial is the gracilis. I think gracil means leg. And of course the adductor longus. So those are the adductors in one abductor. TFL is an abductor. Now we'll see our old friend the sartorius, which has an origin up here in the anterior superior ilium. And it crosses over, that long muscle that crosses over and has an insertion on the tibia. So it has some knee flexion, knee extension, sorry, and some hip flexion. And here's your quadriceps that we could see. Remember, the biggest one is the rectus femoris. Don't confuse this with biceps femoris. Biceps femoris is a hamstring muscle. So the quadricep muscles are for knee extension. So you have the sisters, right? The vastus sisters. You have the vastus lateralis, and then you have the vastus medialis. And they all have a common tendon here called the quadriceps tendon. Remember, a tendon connects muscle to bone. So in this case, the quadriceps tendon is connecting the quadriceps to the patella, the kneecap. Below the patella, you have a ligament, because that's connecting, the patellar ligament is connecting the patella to the tibia. Like this is the part where they hit you with a hammer when you go to the doctor for reflexes, right? They'll hit you with a hammer there. And that'll elicit a stretch in the quadriceps. And the outcome of that reflex, that deep tendon reflex, it's really a stretch reflex. When somebody hits you in the patellar ligament with a hammer, you're going to bring your leg up for the sitting position, and that's leg extension. Quadriceps perform leg extension. Hamstrings are the opposite. They flex the knee, like bringing your heel to your buttocks. That's knee flexion, hamstrings. Quadriceps extension, bringing your leg upward, the opposite. So here's posterior. You can see a nice view of the gluteus maximus, whose function is basically hip extension, extending the hip. And this is a good view of the adductors again, because now I can see that thin most medial. Now this is the right posterior thigh. Now I can see the adductor magnus. So I'm not sure if APR shows you this clearly, but we'll take a look. So gracilis. Here's the iliotibial tract, ITB, band, tract, same thing. Now we're into the hamstrings again. Now here's where I really have to be careful. So this is what I'm going to ask you. Here is the biceps femoris. Leg flexion, hamstring, biceps femoris. Now look, it's showing you the semimembranosus is here, semitendinosus is here, right? But sometimes that switches depending on the dissection. So we have to be really careful here, because this is definitely the semimembranosus. But these two is not so clear, because usually the semitendinosus is more medial. So again, I'm on the recording, so you hear this. The semitendinosus, we're going to go right from APR, not from these pictures. Whatever APR has, that's what we'll use for semitendinosus versus semimembranosus. But make sure you know that these are all hamstrings, right? You know, the biceps has two heads, so it has a medial and lateral, short and long. But you don't have to say short or long head. All you have to say is biceps femoris. Don't say rectus femoris, because that's a quadricep muscle, anterior thigh, leg extension. Biceps femoris is flexion of the knee, heel to buttocks, hamstring muscle, posterior thigh, which makes sense. Then you have a little top of the medial and lateral gastrocnemius muscles here, if you see that. And there they are, the gastrocnemius. There's a little muscle called plantaris over there. Here's your Achilles tendon or calcaneal tendon. And again, if I pointed here and you said the tendon of the gastrocnemius, you'd be 100% correct. But if you put calcaneal or Achilles, you'd still be 100% correct. Whoa, remember this? Medial malleolus, which is the distal tibia. Lateral malleolus is the distal fibula. Calcaneus is pretty simple. That tarsal bone is the heel bone. And look, this is the connection of the Achilles tendon. That's really a tendon of the gastrocnemius and the soleus. They both have the same function, plantar flexion. Okay, let's just get out of here. Let's just take a break for a minute and regroup. And I'll pause the recording. I just want to go through the movements with you on this recording, just so you have an idea of the connections and markings of the bones and the origins, insertions, and actions, and mostly actions here. Now, so these are all actions of muscles or muscle groups. So always look at the arrowheads. That's helpful because that's the direction of the action. So she starts out in neutral. So she's flexing her trunk as she bends forward. So basically she's using her rectus abdominis to do that, right? Extension would be going from here to here. So that's just going back from her flexion position back to neutral. And that you'll use some lumbar muscles and gluteus maximus a bit too. Hyperextension, again, now you're going to use even deeper muscles and go beyond neutral. So basically she's flexing, extending, and hyperextending her trunk, her lumbar area. right? Her lumbar spine, if you want to say more specifically, vertebral column of the lumbar. So here, now she's doing two motions here. She's flexing her humerus or flexing her arm. So in this case, she's going to use her deltoid, her anterior deltoid, and some pectoralis major. And then if she brings it back to neutral, that would be extension. Like this is extension of that. And in that case, she's using her latissimus dorsi and posterior deltoid. Now this is important. Here's flexion of her right leg using the hamstring, the biceps femoris, right? Like if she stepped on a nail, she's going to flex her leg away from the nail using the hamstring muscle, especially the biceps femoris, semitendinosus, semimembranosus. Extension is bringing the leg forward. Like if she was sitting, it'd be easier to show you. So leg extension or thigh extension or, I'm sorry, not thigh extension. This would be lower leg extension, like tibia and fibula extension. Knee extension would be quadriceps muscles. Now here's adduction. Look at the arrowhead. Adducting her arm towards the midline. Abduction is away from the midline. Look at the arrowhead. All right, so abduction is more lateral deltoid, or adduction is more pectoralis major, and some latissimus dorsi as well. Circumduction is basically coming from here. You're circumducting the shoulder joint, which is a ball and socket synovial joint. So the rotator cuff muscles, the sits muscles, can get involved with that circumduction. Now this is rotation of the neck or cervical spine, cervical spinal column or head. You know, your right rotation and left rotation. Like, did I study for this exam? No, I'm rotating. No, I'm saying no. This is hip rotation, lateral rotation, which points the toe out. Medial rotation, which points the toe back to neutral, or even further in. Rotation of the hip. This is rotation of the neck or cervical vertebral column. This is a good one, right? Because now we're showing the anatomical position, which is supinated palm. And if I turn it over, I pronated it. So what's moving? The radius. What's helping that motion? The brachioradialis. Right? And there's other muscles. There's a lot of muscles in the forearm. Like there's a muscle called the supinator and pronator teres. But all you have to know is the brachioradialis. Remember Popeye? If you know who the hell Popeye is. This is an important one. Remember, this is the dorsal surface of the foot. This is the plantar surface of the foot. So this is dorsiflexion, bringing the toes upward towards the shin. And that would be the tibialis anterior muscle. Plantar flexion is pointing the toes downward. All right, and that would be the gastrocnemius muscles, medial and lateral, and soleus. Here's the calcaneus, superficial, right? So you have the Achilles tendon attaches to the calcaneus to bring the foot down. So plantar flexion is downward, right? So let me go back to this, sorry. I got into that hell. So really important. Plantar flexion, inversion, eversion. So this is the left foot. So when she brings her big toe up towards the midline, she's kind of rolling on her ankle. Most injuries, ankle injuries, are inversion injuries because it's just so easy to fall into that position because we have really weak ligaments here. That's really why. Another bad evolution. So we're more likely to have inversion sprains than inversion sprains, although they could happen when you're ice skating or something. So a sprain is basically an injury to a joint, like a synovial joint with the capsule and the fluid and the bursa. So that's more of a sprain. A strain is usually a muscle strain overstretch or tendon overstretch. So you could have something called tendinitis, which is inflammation of a tendon. Like a very common one is your medial epicondylitis, which is the humerus epicondyle, where you have ligamentous and muscle attachment. So the tendon gets inflamed, or the lateral epicondyle of the humerus. There's the muscles that attach via tendons, and that's gets inflamed too. And they call it tennis elbow, lateral epicondylitis. Bursitis is usually an overproduction of fluid from a bursa within a synovial joint. And you should know all synovial joints. So it's excess release, and it leads to pain, swelling, inflammation. Sometimes it gets hardened. So a bursa can cause a hardening around the joint, like a synovial joint. So this is the mandibular motion. Protraction is bringing the mandible back. I'm sorry, protraction is bringing it forward. Retraction is back. Like you can do this with the scapula, like protraction of the scapula with the serratus anterior. So jutting the mandible forward is protraction. Bringing it back is retraction. You don't have to know the muscles for that. Elevation is kind of important because you know the elevation with the temporalis muscle. So closing the jaw is called elevation. Depression of the jaw is opening your mouth. See? Okay. So different muscles used for those movements. Opposition, we didn't learn the muscles of the hand, but opposition is being able to bring your thumb to each one of your fingers. Like the thumb is the first digit, right? The pollex. And you can do that. You go to your index finger with your thumb, touch your thumb to index finger, thumb to middle finger, thumb to ring finger, thumb to fifth digit or pinky. And that's called opposing and then opposition. And the thumb is the only place that does that. So again, go through your list, forward and back, and then go through all those slides. And that's really helpful.